Hey guys, this is Brendan, and I chose to do my case study over a patient with thoracic outlet syndrome. Alright, so a quick definition for thoracic outlet syndrome is that it is the compression of a neural or vascular structure as it's exiting the cervicobrachial region. So what does that mean for the thoracic outlet? That could be the subclavian vein or artery or the brachial plexus as depicted in the picture to the right. So there's multiple different locations where you can have thoracic outlet syndrome, but in most cases, that is 95 to 99% of the cases, you're going to have that impingement of the brachial plexus as opposed to a subclavian vein or artery. And so different thoracic outlets can be marked by the scalenes, pec minor, the first rib, the clavicle, or the thorax. Some factors that might lead to acquiring thoracic outlet. Congenital factors would be a cervical rib, anomalous muscles such as changes in the scalenes or the pec minor, an abnormal insertion of the scalene muscles on the vertebrae, or a prolonged transverse process. And some factors that we may be more likely to see in PT that might not be identified in imaging are postural changes, such as a forward head, rounded shoulders, trauma, whiplash injury, such as a car crash that led to whiplash, a clavicle or rib fracture, and scalene hypertrophy. Now, getting into the specifics here of our patient for the case study, we have a 43-year-old female who presents to the clinic alert, oriented ×4. She reports that she is married with 2 kids in a single-story home. She works full-time at the front desk at a bank. She's a non-smoker, occasional drinker. She rates her overall health as good on a scale from poor, fair, good to excellent. She has an unremarkable family history. So all the information that I presented to you on the previous slide, we received from the paperwork that the patient filled out when she first came into the clinic. Her referral was just simply stated as a numbness of the right upper extremity. Okay, so pretty vague, kind of leaves up some interpretation for us, but my immediate thoughts moving through a differential diagnosis might be a cervical radiculopathy, a thoracic outlet syndrome, a peripheral nerve root impingement, depending on where that numbness is. And those are my top 3 choices for my differential, but I of course still need to rule out things like a rotator cuff pathology, instability of the glenohumeral joint, a malignancy such as a Pancoast tumor, and then maybe even referred pain. It's going to depend a lot on what this patient says when they come in, how their symptoms present, what it really feels like, the intensity of it, because numbness of the right upper extremity doesn't give us a lot to work with. Diving a little bit further into the paperwork that the patient filled out whenever she made it into the office, we had a picture for her to circle where her symptoms were. She circled them in the entirety of her right arm, upper arm, lower arm, and hand, as well as her upper back. So this kind of makes you start to think about your differential, but again, paperwork is not a keep everything still needing to be ruled out. Okay, so getting to talk to the patient, of course, we kind of left everything open-ended, let her tell her side of the story. The big statement that she gave me that kind of stuck out to me was, "My arm just goes numb sometimes. There doesn't seem to be a rhyme or a reason." She also included that her shoulder aches sometimes, but the numbness is what's unbearable. The shoulder ache is just kind of a secondary thing. She reported that with an insidious onset, there was no trauma, no injury that started this numbness. She also reported, when asked about how she's sleeping at night, that at night, the arm I have under my pillow goes numb and I have to wake up and move. So this is impacting her sleep. As she was sitting in the clinic, she had no numbness, so she was a 0 out of 10. But at the worst, specifically at work, she reports at least a 7 out of 10. Her upper extremity functional scale was a 56 out of 80, so really not bad there. But she said she sits for much of the day at work at a desk. She has no history of a neck, shoulder, or back pathology, no history of an organ pathology or long-term medication use that could lead to an organ pathology, no history of a heart condition. She had an x-ray done, but nothing was reported. So with this information, we're kind of starting to work through our differential and what we think's going on. So to get started with our objective portion of the evaluation, start with vitals. As we look through everything, the blood pressure, heart rate, O2 sat, and respiration rate, those things are all fine. They're all within normal limits. So that's good. A good thing to immediately rule out. Inspecting the patient just as she sits in the chair that we're talking to her in. She's got a forward head, rounded shoulder posture, which I assume she probably has the same posture at work while she's working at a desk. But overall, she's got a healthy build for her gender and age. Based on what we know now, thinking about our differential list that we created earlier, most of our things we haven't ruled out. When we think about the referred pain from the organs such as the heart, lungs, and diaphragm, potentially referring up into the upper extremity, upper shoulders, her vitals looked good. She has no history of an organ pathology. We're not going to rule those things out yet because we still need to make sure that we can recreate this pain and numbness mechanically, but we're starting to think that potentially referred pain might not be the answer. Now getting into our basic clinical exam, where we're hopefully going to find some answers as to what we're looking for here. Being a pathology that's related to numbness and tingling in the upper extremity, we really need to start with the cervical spine, start thinking about a cervical radiculopathy. So with our flexion, extension, they were both within normal limits. We had no issues there, no exacerbation of symptoms. With her side bend and rotation to the left, she reported that they felt tight. And that could mean a number of things. It could just mean that since she sits at a desk all day, has her right hand on a computer mouse, that her upper trap scalenes might just be tight. It might not be related to the problem. Her shoulder girdle movements, all grossly within normal limits, but her retraction, she also said, feels tight. That could just be related to her forward head, rounded shoulders posture. So we're starting to see some deficits here, maybe some muscle tightness, but no clear answers yet. Moving on through our basic clinical exam, we started out with some passive tests of the shoulder. All of the motion was within normal limits. It was full range of motion. With abduction, however, she did report some minor numbness and tingling whenever we left the position of end-range abduction, but it went away before we even reached her neutral position. So we had some reproduction of symptoms, but not a great amount. A few shoulder active tests that we did tested her strength grossly. Her strength was fine. There were no limits anywhere. We did a near test. It was negative. And a liftoff test to test for the rotator cuff, and it was also negative. So the rotator cuff seems to be intact, and there doesn't seem to be any impingement issues. Moving through some further special testing, we started out with some labral testing, such as a crank test and an O'Brien's test, both of which were negative. The apprehension and relocation testing was also negative, so we kind of ruled out an anterior instability with that. Sperling's test was negative. This was a very important test to administer to rule out a potential cervical radiculopathy. Reflexes, on both sides, comparing left to right, they were normal and symmetrical. And doing some palpation, she reported some tenderness to palpation of the pec minor and upper trap region. To really narrow down our special testing with what we thought was potentially the most likely diagnosis with our thoracic outlet testing, we did an Adson's test, which was negative, which meant that the radial pulse did not diminish whenever we changed positions. But the Roos test and the Crx Release Test were both positive and recreated her symptoms upon administering the test. Reflecting back on our differential diagnosis list, we have some things that at this point we can potentially rule out. So that cervical radiculopathy, we weren't able to recreate any symptoms with active movements of the neck or any special testing of the neck. The rotator cuff was intact based on strength and special testing. The glenohumeral joint was stable based on our testing. We were able to recreate the symptoms mechanically. This is a big one for this last two, that malignancy of the potential pancreas tumor and the referred pain. Because we were able to recreate these symptoms of numbness and tingling, it meant that this is likely more mechanical in nature as opposed to related to something such as a malignancy or a vital organ. So those highlighted structures in yellow, we can potentially rule those out now, but we need to make sure that we're on the right track with our final diagnosis. Some final special testing, we know that we were able to recreate the numbness and tingling symptoms with our testing, but we need to make sure of where those structures are being impinged. So we did a Tunnel sign on structures such as the carpal tunnel, the cubital tunnel, and the pronator teres, and we weren't able to provoke any symptoms with that. So likely the symptoms are being caused somewhere higher up on the chain. We did some nerve tension testing on both sides. On both sides, getting that nerve into its most stretched position, she reported that it was uncomfortable, but especially on the right side. And that was with all three major nerve tests that we did. So ulnar, median, and radial. She quickly reported that it felt very tight. She didn't have numbness or tingling, but it felt much more uncomfortable on the right side compared to the left. So we conclude our basic clinical exam and our special testing. At this point, we've got a pretty good idea of what's going on. We think it's a thoracic outlet syndrome. So now we need to convey this message to the patient. We start out with, what is thoracic outlet syndrome? This is what we're going to tell the patient. I actually pulled up a picture on my laptop to show him. I said, hey, up here in the shoulder, near the shoulder girdle, there's a lot going on. There's muscles that connect from your neck to your first rib. There's muscles from your shoulder blade down to your ribs. There's nerves, arteries, veins that intertwine through all of this. And it sounds like these structures are becoming impinged, specifically the nerves. That's where you're getting your numbness and tingling. She asked, will my condition improve? I told her absolutely. There are a ton of different things we can work on through the muscles. We can work on some stretching, some soft tissue techniques. We can work on some nerve glides, some strengthening of her posterior muscles to help out with her posture. And we can start working on her posture that she has at her desk at work, because that likely is leading to some of her symptoms. So she had a pretty good outlook on what we were able to do, but she said, is this normal? And so I had to pull the statistics on this, but I told her that approximately 8% of the population will deal with thoracic outlet syndrome to some degree at some point. And being a female, she is 3 to 4 times more likely to deal with thoracic outlet syndrome for a number of reasons. So especially for her, it's a normal condition. So I told her that the first thing that we need to do is establish some goals. What are we working towards in physical therapy? So we need to work on getting some exercises that she can do at home so that she can be working on this condition every single day of the week. She actually recognized herself coming into the evaluation that her posture is not that great because she sits at a desk all day. And so I told her, let's learn some postural cues that you can work on during the day. I want to see you become independent with your home exercise program. And to mark that we're moving in the right direction, we need to see a decrease in your pain levels, your intensity, and your frequency of symptoms in the short term. Long term, we really want to improve her ability to sleep because that's going to aid in the healing process. We want to decrease the frequency of her sign and symptoms to 1 time per day, as on her evaluation day it was multiple times a day, and then further as a long-term goal, maybe even decrease it to 1 time per week. Overall, we need to improve her upper extremity strength to 5 out of 5 in all planes. We can show some objective progress by improving her upper extremity functional scale score to at least a 75. Like we said earlier, it started out as a 56, so it's really not a bad score at that point. And then we really need to learn some scapular control that's going to help her throughout the day. So typically we like to structure our therapy sessions with some manual therapy at the beginning to help loosen things up. With that Crx Release Test, we can actually hold that position and work on some habituation of those nerves, releasing them from their position to improve the symptoms. We can do some pin and stretch to the pectoralis minor, which may be impinging some nerves. We can do some first rib mobilizations because of its strong relationship with the scalenes. We can work on the thoracic and costotransverse mobilizations, and also some soft tissue techniques directly to the scalenes. And if you're not familiar with the Crx Release Test, here's what that position looks like, where the practitioner is passively elevating the patient's shoulders to relieve some tension on the brachial plexus. That release phenomenon occurs whenever the nerve is released from that impingement and is able to breathe again. Here's an example of a first rib mobilization. You can also do a first rib mobilization in a supine position, but when we tried that with this patient, she said she wasn't really feeling much with it. With the position in the picture here, we were able to get a little bit more force with our mobilization hand and control what the head was doing. So we were putting the scalenes on slack with the head, and we're mobilizing the first rib in a downward direction to try and get some more movement in there to allow that nerve to have more room. Another example of taking our evaluation into our treatment is that we can use that nerve tension testing as a sign that maybe those nerves need a little bit of mobility work. So I've got pictures here of the ulnar, median, and radial nerves, how we can do some flossing with those nerves. And so the difference in a nerve tension test and some flossing is that instead of putting stress through both ends of the nerve, one end, we'll be working to shorten the nerve. So we're just kind of working on flossing it through that thoracic outlet and reintroducing some healthy movement. Some strengthening that we introduced specifically to work on the posture that this patient seems to be stuck in. We started with some lower trapezius strengthening, such as prone Ys and a modified seated latissimus dorsi pull down. We worked on some rhomboid strengthening to work on the retraction of that scapula with some prone Ts and some standing horizontal abduction, and then some posterior rotator cuff strengthening. We identified that external rotation was a point of weakness in our basic clinical exam, so we used that as guidance for somewhere that we needed to work on some strength as well. So that was a lot to take in, but obviously we didn't want to overwhelm the patient with a laundry list of exercises, so we sent her with 2 stretches and 2 strengthening exercises to start. We had her doing a pec minor stretch as shown in the doorway there, keeping the arm in that closed chain position while moving the torso, and also a scalene stretch where she's sitting on the back of that towel, moving the head through retraction, extension, side bending, and then ipsilateral rotation to get a stretch on the scalenes with the first rib pinned down. To address some of that rotator cuff weakness through the external rotation, we had her doing some W's here, as we saw earlier in an earlier slide, and also some prone Ys. These prone Ys for her were really important to get the scapula in a better position from that rounded shoulder posture that she seems to have developed over the years of working at a bank. Lastly, we sent her home with a Crx Release Exercise as opposed to a special test, where everything is exactly the same, she just does it by herself. So she padded up the armrests on a chair, put her arms on top of those armrests, and then let the shoulders sit in a relaxed but elevated position. I have a picture on the next slide as to why this release phenomenon occurs. So we had the patient holding this position for up to 30 minutes, a couple of times a day. What would happen was her symptoms would come, and then the longer that she would sit, they would start to alleviate. And as shown in this picture, it's because of the elevation of the scapula opens up that thoracic outlet space and lets those nerves breathe a little bit, lets them get some movement. They start to tingle whenever they're open again, and then eventually she becomes habituated to the position. So in relation to her question from earlier about will I get better, and thinking about the prognosis, some identifiable factors that might lead to a poor outcome with thoracic outlet syndrome are obesity, if it is a workers' compensation case, and if there's associated peripheral nerve entrapment. Now we know she has a healthy build for her gender and age. We did a Tinel test and we weren't able to recreate any signs and symptoms with that. And she was never actually off work for this symptom. So she's 0 for 3 there, she's good there. We were able to reproduce but also sensitize her to her symptoms with a Crx release, which is positive. She reports that she's very compliant with her home exercise program, doing it a couple of times a day, and she reports immediate improvement whenever we would do manual therapy techniques. So for us, we think she's a very good prognosis because she's reacting well to therapy and she's compliant at home. So by the last time that I treated this patient, she was about 80% through her therapy goals. She still had some minor numbness and tingling throughout the day, but it was generally only once per day. She wasn't completely symptom-free, but the symptoms had improved. She was independent with her home exercise program. Her external rotation strength and her initiation of the movement had improved significantly, and she was so much less stressed about her condition. When she first came in, she had a lot of stress regarding would she get better? Is this something she would have to deal with the rest of her life? And she was a lot more comfortable with the situation by the last time that I saw her. She knew she was getting better. She knew that physical therapy was right for her, and she was happy to be on the road to recovery. So she had decreased to 1 time per week by the time my clinical ended, and she was very close to meeting her goals and to being done with therapy.